And here is your question. Right. So if you have read and understood, considering it.
Hello, I'm Dr.
I'll
Bharat.
begin. Yes.
I am Dr. Bharat, one of the surgical resident. May I confirm your name and age, please?
Hello, I am Alex. I'm 64 years old.
Okay, Mr. Anit. May I know what has bring you today here?
Yes, I have passing of blood when I pass stool.
Oh, I'm so sorry to hear that. Okay, do you feel giddy right?
No, okay.
Okay. So is it okay to proceed further regarding your problem?
Yes, sure.
Okay, thank you so much. So can you please elaborate upon your bleeding in the stools? When did it actually started?
It has been started about 2 days ago.
Okay. It started all of a sudden, or it was initially very less in quantity and increased in quantity later?
Yes, it started suddenly.
Okay. Do you feel it is becoming worse within these 2 days?
No.
Okay. Can you please tell me how much is the quantity of blood you have lost for every episode?
It is only small amount.
Okay. Do you feel pain while passing this bleeding during stools?
Yes, I feel like I have a pain in my tummy.
Okay. Can you please locate exactly regarding the pain? And before I go to that, can you please tell me anything which aggravates this bleeding or anything that resolves this bleeding?
It is more like associated when I have constipation.
Oh, I all right. You told me about pain. Can you please elaborate on your pain? Where did it actually started?
Yes, it is here, just in the center of my tummy.
Okay. From how long it is there?
It is about 5 days.
5 days. Okay. Can you please tell me that whether this pain is going behind or coming front, anything like that?
No, it is just over here. It doesn't go
Okay.
anywhere else.
Do you feel that anything relieves this pain or aggravates this pain?
I feel like the pain is relieved when I pass stool.
Okay. Can you, on a scale of 1 to 10, 1 being minimum and 10 being a major, how can you rate your tummy pain?
It is about 7.
Okay. Can you please tell me regarding your problem of constipation? How long it has been there?
It is constipation. It is for only 2 weeks ago.
Okay. Have you ever noticed these complaints previously?
No, this is the first time I experienced that.
Have you noticed weight loss regarding this phase?
Yes, I have lost about 10 pounds over 6 months ago.
Oh, I'm so sorry to hear that.
It is really troubling me.
I am so sorry to hear that, your situation. Can you please tell me, when you are passing stool, do you feel any slime or discharge?
No,
Mucus?
I don't have.
Do you have any red eyes and joint pains?
Yes, I have joint pain in my knee.
Okay. I'm so sorry to hear that. Do you like to have a seat, or it's okay to continue?
Yes, it's okay.
Okay, thank you. Can you please tell me, do you have recently traveled anywhere?
No.
Okay. So before I proceed further, have you ever visited any GP regarding your problems or for any other problem?
Yes, I often see your GP, like I have a hypertension.
Okay. From how long you're having this hypertension?
Just about 5 years ago.
Okay. Have you taken any medications regarding this?
Yes, I take pills, but I don't know.
Okay.
It didn't break it
Okay.
with me.
Okay. Before I proceed further, can I ask you a few personal questions?
Okay.
What is your occupation?
I'm a farmer.
Okay. Whom do you live with?
I live with my wife and with my children.
Have you ever smoked or drink alcohol?
Yes, I'm a smoker,
How
but
many
I
packs
don't
per
drink.
week? Okay.
I take about 4 to 5 packs per day.
Okay. Can you please tell me what do you think the cause is?
I don't know. Is it something bad?
Okay, that's all right. I'll explain you in detail regarding that after discussing with my consultant.
Okay.
What is your most concern about?
My most like is this maybe a cancer. I don't know.
Okay. What do you expecting from us to do?
I expect you just relieve my pain and I don't like this bleeding. It is really annoying me.
Sure, I'll do my level best after discussing with my superiors. Can you please tell me a few more questions? Have you ever, any member in your family has been suffering from this?
No,
Okay. Do you ever had chest pain or difficulty in breathing?
no, I don't have.
Can you summarize your
Okay.
history now, please?
Yeah, please. So, Mr. X, 64 years old male, came with complaints of bleeding in the stool since 2 days. It is associated with tummy pain. And he also had given a significant history of loss of weight, approximately 10 pounds within 6 months, which is significant. Also a known case of smoker and hypertension and on medication. And he has been visiting his GP regularly for the given complaints. So as per the given history, my most probable diagnosis would be, it can be a diverticulosis of colon, or it can be a colorectal malignancy.
Okay. So what are the most important investigations that you can ask for this patient?
Most important investigation is first I would like to perform if OPD basis, I would like to perform a rigid sigmoidoscopy and look for any diverticuli, or I can liaise with the gastroenterologist and plan for a colonoscopy to look for any any growth and to look for a take for a biopsy. And apart from this, I would also plan for an upper gastrointestinal scopy to look for any upper GI causes. Along with this, I would like to also rule out a blood investigations for normal hemoglobin and platelet count to look for any thrombocytopenia. And I also plan for a coagulation profile and serum electrolytes. Along with that, I would like to do for an X-ray abdomen erect and CT abdomen to look for any features of intestinal obstruction.
Okay, what are the management options that you can offer this patient?
Management options basically depend upon my diagnosis. If it is a case of diverticuli, I would like to do a stapling, or if it is a malignancy, I would like to discuss with the tumor board meeting for further management.
Okay, good. Thank you. Now,
Thank you.
feedback. Yes. Can you begin first, Dr. Mohammed?
Yes. First, he was confident and he has clear voice.
Yes.
But I think he was in hurry. Maybe
Okay.
he's a busy.
Yeah.
Yes.
How did you realize that? What Did you notice anything
He
adequately has
didn't,
missed?
when I said that I have abdominal pain, he didn't ask me about the Socratic onset and character radiation.
Okay.
He asked about the radiation.
He didn't ask about the stool changes.
Yes.
Habit
He did.
recently, like how it progressed.
And also about anal fissures, anal causes.
Correct. I missed
But he
about
did
anal
ask
fissure. That
about
is
the
important.
travel history.
Yeah.
Yes.
And the
I missed.
blood, if it is mixed with the stool or it comes afterwards, the color of blood, he did ask
Yes, the
you
color.
amount and you said little bit, but then he didn't ask you to specify it, that how, what do you mean by little bit? Is it just few drops, the fresh drops, or is it like,
Teaspoon, cup,
one, yeah, half teaspoon or 1 cup? So amount
drink.
is also important. And if it comes before or mixed or after stool. So yes, okay. Good.
Also about the past medical history, he didn't ask about the previous surgery or allergic to any medications.
Okay, but he did ask you about the current medications that you are taking.
Yes.
Yes. Okay, good.
So
Yeah,
overall, I
and he
think
did
he's
ask
good.
you
Yeah.
about systemic. Did he ask you about weight loss, or you told yourself?
I have asked about weight loss, ma'am.
He asked it, yes, about that.
Yes. Weight loss has been discussed, and family history has also been discussed. Social history has also been discussed. Most of the things he has covered. It's just the anal, yes, differential diagnosis. And one question that once you're considering, this is very important, because once you are taking history, and you have to consider the history, and according to the history, you placed diverticulitis as number 1.
Yes.
Do patients with diverticulitis weight significant amount of weight loss? Like, do they suffer through significant amount of weight loss? Because since you didn't exclude stool changes, like, yeah.
Okay.
So,
but it was
most
complete.
like,
It was only duration of 2 days, madam. That's why I have considered it.
It's from 6 months. From 2 days, it's more. With or without 6 months, but 10 pounds of weight has been lost in recent weeks.
Okay,
Now,
madam.
for
So
2
you
days,
need to
it's
keep
constipation.
as a colorectal malignancy. Maybe.
Yes, that's what I want to focus more on. So number 1 will be colorectal carcinoma. Number 2, you can have diverticulitis, hemorrhoids, anything else, right? And at least try to give 3 to 4 differential diagnoses, because once you are giving 1, 2, 3 quickly, one after another, 3 diagnoses, by the time you'll reach 4th, examiner will realize that you already know this, so they will ask you the next question. And secondly, you didn't wait for me to ask you differential diagnosis, because I only asked you to summarize your history. So you should have only stayed there, and then should have allowed me to ask you, okay, so what are your differential diagnosis? Because if you'll answer without
sorry,
me
ma'am. I
asking,
thought you have asked about the differential diagnosis.
you'll miss one point, and your aim is to score maximum points as you can.
Sure, ma'am. Sure, ma'am. Next time I'll cover it up, ma'am.
Yes,
Understood.
definitely good. Thank you.
Thank you, ma'am. Thank you.
Here is your question. Yes. If you have read and understood, considering it critical care scenario, kindly tell me, how would you manage this lady now?
This is being a critical care station, so I would like to manage the patient according to the CRISP protocol.
Good.
That include ABCD. I will check for the airways, any obstruction in the airway, and then check for breathing, the movement of the chest, and any injury to the chest. And for circulation, I will take 2 whiteboard cameras and will take samples for CBC, LFT, KFT, and coagulation profile. And then I will try to resuscitate her with IV fluids. And for D, I would like to check her Glasgow coma scale, her pupillary reflex. And for exposure, I will look for any other injury.
First of all, patient has presented with a very low body temperature. Can you tell me what is the normal acceptable low body temperature? When
the
is
core body
yes,
temperature should be 36.
it's how much?
Less than 36 is hypothermia.
Is considered hypothermia. Okay. Can you please tell me how would you, or what are the possible ways by which you can measure core body temperature?
So we can know the temperature from tympanic membrane, esophagus, rectal, or axillary.
Oral and axillary. Okay.
Oral and axillary.
This patient has a body temperature of 26 Celsius. So can you tell me how do you classify low body temperatures?
No, ma'am, I don't know. Pass.
Okay. Right. What would you do, or how would you warm up the patient?
So I would give her warm IV fluids, and I will give her warm blankets and warm blankets and space blankets. So and
Can
warm
you
IV fluid.
please tell me what might have caused this low body temperature in this patient? In what kind of, yes, if you can elaborate.
Cold water.
Okay.
Cold water.
That has resulted in what?
Hypothermia or heating.
If you fail to warm up the patient, so what are the complications of hypothermia that can occur?
In hypothermia and cardiovascular, it can lead to arrhythmias, bradycardia, and in respiratory, it can lead to respiratory depression and decrease ventilation perfusion. And in coagulation, it can lead to decreased platelet count, which can lead to hypocoagulation and decrease in the number of clotting factors. And
Okay.
it can in kidney, it can lead to decrease in GFR, and so less urine output, and it also decrease the basal metabolic rate. So yes.
This patient has impaired arterial blood gases as well. So what is the condition and how would you correct the patient's ABGs?
The pH is 7.12, so it is acidosis.
Yes.
And potassium is 8.5. Base deficit.
Yes. Yes.
So it is a metabolic acidosis.
Yes. Then how would you take care of hyperkalemia?
By hyperkalemia, I would like to give her insulin with dextrose, and then salbutamol infusion, nebulization, or sodium bicarbonate.
Okay, can you please tell me or mention few mechanisms because of which person can have or can result into hypothermia?
It can be heat loss due to radiation,
Okay,
which is due to cold objects, and other is conduction,
yes,
convection, and evaporation.
okay. Can you define conduction?
Conduction is when the body is touched against cold surface, so the heat loss takes from that.
There are certain factors which also contribute towards hypothermia, especially when you're operating a pre-operative patient or during surgery. What are those? Can you mention few?
So it can be due to the effect of the anesthesia drugs and prolonged surgery,
Yes,
massive bleeding during the surgery,
yes,
or massive blood transfusion during the surgery.
yes. What are
And
the
the cooling-
measures that you can take to reduce the risk of hypothermia?
So before inducing the patient for anesthesia, we should check for the core body temperature should be more than 36, and we can use warm IV fluids. And
According to
we
NICE guidelines, there are certain, there's a certain list, if you can tell me. Theater temperature should be kept at 21. What are other?
theater temperature should be 31. Core body temperature should be more than 36, and space blankets, use of space blankets, and beer heater,
Warm irrigation, IV fluids.
warm
And
irrigation, and minimizing the duration of surgery.
okay, and least
And the
exposure.
patient should not be shifted to the post-op unless his temperature should be more than 36.
Okay. Can you please tell me right, actually, can you please tell me how do normal people generate heat to warm themselves up?
So it is due to the metabolic activity, the basal metabolic rate, and shivering also helping generation of the heat, and hypothalamus also contribute towards the
How? What is the
maintaining the
mechanism?
temperature.
What is the role of hypothalamus?
I don't know the mechanism.
Okay, can you please tell me if a patient during surgery can generate heat?
No, because the loss of the central injection, the defect of the anesthesia will lead to the loss of the shivering, and decrease. There will be decrease in basal metabolic rate and the muscle activity. So the heat loss will be less.
Okay, thank you.
Thank you.
Right, so if you have read and understood considering a surgical pathology patient, kindly tell me what are your differential diagnosis for this patient?
My top generation diagnosis is familial adenomatous polyposis.
Okay, good. And this is provisional diagnosis and others?
Others are Crohn's disease, ulcerative colitis, and Gardner syndrome.
Good.
And
Okay, how would you confirm your diagnosis?
confirmed by screening and
Yes, what investigations are included in screening program?
including screening program will include colonoscopy and biopsy.
Okay, can you tell me, according to the NICE guidelines, what are the, if a patient just like this one has a family history, so what is the follow-up plan, or what is the surveillance program it is called? How is it carried out?
If the patient we done colonoscope screening by the age of 20 if there is a positive family history.
That is too late, you're telling me. You have to read that again. Okay, can you please tell me what would be, like, you've done colonoscopy in this patient and there were multiple polyps. The largest one was 7 millimeter and it was ulcerated. What would be your next step?
Next step,
How would you
I'll
manage this patient? It's another easy question.
I'll take the history and go for a few investigations, and then I'll approach multidisciplinary team, and uh, for specific treatment I'll go for total colectomy with indolestome. Total colectomy.
What kind of condition is familial adenomatous FAP?
It's a autosomal dominant condition.
How does it occur? What are the genes involved in it?
APC gene, APC, that is APC tumor suppressor gene on the long arm of chromosome 5.
Any other genes? What is the role of P53 in this condition?
P53 genes, and there's three major functions: that growth arrest and DNA repair and apoptosis.
Okay, just pause. Presence of these genes can lead to
yes,
yes.
Yes, ma'am. This and the growth arrest that stops the progression of the cell cycle, and then prevent the replication of the DNA, damaged DNA. And during the growth arrest, this gene, that is P53, activates the transcription process.
Okay, these genes are responsible for causing what type of colonic cancer?
Sorry, ma'am.
These genes are responsible for causing what type of colonic carcinoma?
What type of colonic carcinoma?
Yes.
Sorry, ma'am.
What are the common carcinomas of colon?
Adenocarcinoma.
Adenocarcinoma. Okay. These different genes, they lead to, one leads to hyperplasia, one leads to dysplasia, and
Yes, ma'am. Loss of APC gene causes hyperplasia, and
yes,
KRAS gene mutation causes dysplasia.
so
And
can you
loss of
define the
P53
term dysplasia?
Yes, dysplasia it is a disordered cellular development that characterized by increased mitosis, and there would be pleomorphism, and there absent would be pleomorphism, and there is a inability to invade the basement membrane.
Can you please tell me what are the different types of adenomas that you know of?
Different types of adenomas. Uh,
So there is non-neoplastic, there is
yes, ma'am. There is a non-neoplastic, inflammatory, and
hemato
neoplastic.
and
Yes, ma'am. Non-neoplastic are hematomatous and metaplastic,
Hmm?
and inflammatory are pseudopolyps and ulcerative colitis, and neoplastics are villus, tubular, and tubulus.
Which adenoma has more or is a risk factor for causing malignancy or has the
Yes, ma'am.
highest risk?
Villus adenoma.
Okay. Can you tell me in case of adenomas, this malignant potential, it depends on what?
Depends on diameter, type of adenoma
Very
and the
good. And
diameter of the
yes,
adenoma and the degree of dysplasia. In case of diameter, if there is one less than 1 centimeter, the percentage becomes 5%, and if more than 1 centimeter, then it might be 20% or more.
can you please tell me, according to Duke's classification, how would you categorize or how would you explain the condition? If a patient presents, just like a patient has this lesion that you're looking,
Yes, ma'am. In Duke's criteria, in Duke's A, there is confined, the lesion confined to the mucosa. In Duke's B, there the lesion present through the muscle, that is muscular propria, and in the Duke C, the lesion involved in the lymph nodes, and the Duke D, there is distant metastasis.
in this image that is in front of you, how would you describe patient's condition?
There is a multiple polyps in the
Yes,
lesion,
and
the and ulceration, presence of ulceration.
different polyps, are they all of the same size?
All are the same size. Yes.
Are they? No, they are they are of different sizes. So which one are you looking at which has ulceration? What is this yellow fluid or okay, can you please tell me some extracolonic fat features?
Yes, ma'am. Extracolonic phage, familial dermatitis coli are ectodermal and some mesodermal and endodermal. In case of ectodermal, there is epidermoid cyst and brain tumor and congenital hypertrophy of the retinal pigment epithelium. And in mesodermal, there is osteoma, odontoma, and desmoid tumor. And endodermal, there are adenoma carcinoma stoma, and small bowel carcinoma.
Okay, this patient also had endometriosis. Can you please tell me, can you first define the term endometriosis?
Yes, ma'am. The endometriosis is defined as the presence of ectopic endometrial tissue other than the uterus.
Can you tell me why this patient experienced pain?
Sorry, ma'am.
Why this patient with endometriosis experienced pain?
Sorry, ma'am. There might be fibrosis
Yes.
and obstruction.
Okay.
Sorry, ma'am, I
Is there
can't remember.
is there any association of endometriosis and a FAP condition which is associated or related to malignancy?
Yes, ma'am. There risk of ovarian carcinoma.
Patient. Okay, good. Right. Thank you. And here is the
Okay.
question. right? So if you have read and understood considering it clinical examination station, kindly tell me.
Okay, I will enter the room. I will wash my hands. Hello, I'm Dr. Muhammad, an obstetrical doctor. Today I have been asked to examine your limbs. This will include feeling and listening, and also moving your limb. Are you okay with that?
Yes.
Okay. I will expose the patients from the groin down. The patient should be lying down. Okay. I will start by examining the hand. First, I will inspect for any splinter hemorrhage or any nail impact, and also any skin change. And also I will inspect for tendon exansmota, and also I will feel the pulses, the radial pulses, and also I will do capillary fill. Also, I will do the radial, looking for any radial delay. Then I will move to the lower limb. First, hair losses or shining of the skin or thinning of the skin. And also I will look for any skin scars like surgical scars. Also, I will look for any color change, like color or any color change or black discoloration. Also, I will look for signs of chronic skin ischemia, like dermatosclerosis or an eczematous change. Also, I will look for any ulcerations or loss of tissue, like look for any scar like amputations, and also atrophic pulp of the toe. Also, I will look between interdigit. Also, I will ask examine the actor to elevate his limbs to look under the legs. After that, I will palpate. I will look for any
No.
palpate.
You didn't ask the patient to walk for you, or you didn't notice the gait of the patient?
The gait. Okay. I will ask the patient to move. I will look for the gait. Then I will ask the patient if there's any pain. Then I will palpate for the temperature. Also, I will like to palpate for I will do the Bergel angle and the Bergel test. A patient should lie flat. I will elevate the limbs about 10 degrees for 10 seconds. Then I will look for any pale or skin change. Then I will raise the limbs another 10 degrees till 90 degrees. If there is any pallor or skin change, then I will swing the legs down to the ground, look for any
Are you
skin
doing
change.
movements now?
Yes.
Would you, which movements would you prefer? Active movements first or passive movements?
First passive movement, then
Yes.
active movement.
Yes. No. Okay, continue.
Okay. Then after that, I will palpate for the peripheral pulses. I will palpate for the femoral artery and the popliteal artery. Then I will palpate for the dorsalis pedis and the posterior tibial artery. If there is no palpable pulse, then I will go for the Doppler ultrasound. After that, I will examine the other limbs the same way. Then I will do the ankle brachial index by doing sphygmometer, and after that, I will thank the patient and cover the patients. I would like to complete my examination by doing the cardiovascular examination and abdominal examination, and also neurological examination, and also vascular and neurological examination of the upper limbs.
Yes, but you still have 1 minute, and there's still much more that you could have covered. What special tests have you done? Have you checked for the sensation?
Just for the temperature.
No pinprick or light touch. You have to rule out the sensations, and then tone, clonus, coordination.
Is it for neurological or vascular examination?
You have to rule out, is it vascular or is it neurological, or is it both? How would you differentiate? I know you're doing vascular, but then how would you differentiate between the two? And how the examination would differ for both of these?
For the neurological examination, I will not do the ankle brachial index pressure. Also, I will not do the Doppler ultrasound.
Here, have I mentioned any ABPI, like patient has, how much patient takes walks, okay? Cannot walk like he used to do before. Because I thought this is neurological examination, but patient is diabetic as well. So how would you rule out which test would you do to rule out if it's neurological or it's vascular?
Mom, I think there is another station for the neurological examinations. Should I do the same for the both stations?
No, there's difference.
Because in this vascular examination, correct ischemia,
This is ischemia, yes.
I think I will not ask the patient for those coordinations on the pinprick skin test.
Because patient is diabetic, so you have to feel the sensations as well. What I was thinking, because even it's part of for diabetic patients, for the leg examination to rule out ischemia, chronic limb ischemia, you do pricks and the cotton test as well. So that you have to do. I don't know, are you even like whatever you were doing, you didn't mention many of them. So the examination that you have told me, it does not become either neurological, either vascular. This is what my concern is.
Okay.
Yeah, and in the, here is your question. Right, so if you have read and understood, considering this cervical anatomy station, kindly tell me what image are you looking at?
These are the mediastinal surface of right and left lung.
Very good. Okay, can you please tell me what are the structures which pass through the hilum of the lungs? Is there any difference in right or left lung? So can you tell me please for both?
Yes, ma'am. In the right lung, there is right superior
Superior to
bronchus.
inferior, yes. What structure pass?
Right superior principal bronchus
Yes,
and right pulmonary artery.
yes.
And the right inferior bronchus and right pulmonary vein.
Good. And the left side?
Left side, ma'am. left pulmonary artery and left principal bronchus and left pulmonary vein.
Good. Okay, can you please tell me at what level the root of the lung is located?
Thoracic 5, 6, 7.
Okay, can you please tell me this impression in the right side, the left-hand side image? It says 3. Can you identify its impression of which?
It is due to arthropathic.
Okay. Okay, and 8, please.
Esophagus.
Esophagus, yes. The impression of 10 is in the, this is impression of what? Okay, we'll do that. Yes, on.
Sorry.
All right, can you please tell me both right or left lungs, how many lobes and how many fissures they have?
In the right lung, there is 3 lobes and 2 fissure, horizontal and oblique. In the left lung, there is 2 lobes and 1 fissure, oblique fissure.
Okay, can you please tell me the surface anatomy of the lung on the skeleton, both right and left?
The apex is drawn from the sternoclavicular joint and medial 1/3 and lateral 2/3 of the clavicle. And from these 2 points above 3 centimeter, and
Yes.
the anterior border is marked from sternoclavicular joint to the GP-sternal joint on the lateral side of the sternum, and the inferior border is marked by 3 points. At the mid clavicular joint on the 6th rib, at mid axillary line, and at the 8th rib, and on the lateral side of the vertebral column, 10th rib. By joining the 3 points, the inferior border.
Very good. Okay. Can you please tell me what is this 8?
Ma'am, it is pulmonary ligament.
What is pulmonary ligament, please?
It is a continuation of the visceral pulmonary visceral and pleura, which is formed and which gives the space for the pulmonary vessels during expansion and blood flow.
Expansion, yes, so during blood flow. Yes, good. Can you please tell me in both lungs how many bronchopulmonary segments
10
there are?
10 bronchopulmonary segment in each lung.
Okay, can you please also tell me the nerve relations anterior and posterior to these both lungs?
Anteriorly, phrenic nerve passes in front of the root of the lung, and
Yes.
posteriorly, vagus nerve and cardiac plexus of nerves.
Good. Can you please tell me if there is a clot which is there present in the deep veins of the calf? What is the route this clot will adopt to reach the pulmonary artery?
And this will passes through popliteal vein, through femoral vein, through common iliac, right or left common iliac vein, then inferior vena cava, through the right atrium, and through the pulmonary artery to lung.
Good. Okay, can you please identify in picture 1, 2, 3, and 4 the labeled structures, please? What is 9? What is 10? What is 7? If you can.
9 is oblique fissure and 10 is horizontal fissure.
So that means this is right lung.
Right lung and
Okay, 2, please.
it is horizontal oblique fissure, ma'am. This left
Yes.
lung.
Okay, if you can identify 1, 2, 3 in picture 3 and A and B. So this is the hilum.
Pulmonary artery.
Okay, if you can identify any structures in picture 4, 5, and 6. This is also hilum of the other side. Okay, can you define the term mediastinum?
Mediastinum is the space in the chest wall, chest cavity, which is confined with superiorly in the thoracic inlet, inferiorly diaphragm, and
Yes.
and laterally mediastinum pleura, and posteriorly by vertebral column, and anteriorly by sternum.
Good. How would you divide mediastinum?
Mediastinum, first of all, we can divide its superior and inferior mediastinum by a line, imaginary line, which is drawn from external angle to the fourth thoracic vertebra.
Yes.
And inferior mediastinum is again divided by 3 by anterior mediastinum, middle and posterior mediastinum.
Can you please tell me the boundaries of the posterior mediastinum?
And posterior mediastinum is bounded by superiorly by the imaginary line from the external angle and T4 thoracic vertebra, anteriorly by pericardial sac, and posteriorly by the from T4 to T8 vertebra, and
on each side?
on each side there is mediastinum pleura.
Very good. And the floor is diaphragm. Can you please tell me the contents of the posterior mediastinum?
The posterior mediastinum, there is esophagus, descending thoracic aorta, adagos hemiadagos vein, splanchnic plexus of nerve, and thoracic duct.
And sympathetic trunk.
Sympathetic
Right. Can you,
chain.
in the image in front of you, there are 3 red arrows. Can you please identify at least this arrow, which is pointing at 27
sympathetic chain.
and 3? Can you tell me the course of sympathetic chain?
3 means this is phrenic nerve. So,
Yeah. Can you please
C3,
tell me the
C4,
course
C5.
of the sympathetic chain?
phrenic nerve, this is formed by the C3, 4, 5, and which passes between the
You're telling me
in
the
the right-
course of phrenic nerve.
so I sorry, I cannot understand the question. Please, can you
Yes,
please
I asked
remind me?
for sympathetic chain because that is also part of the posterior mediastinum, content of the posterior mediastinum. So I was asking you, but then you can tell me later. That is fine. Okay, good. Thank you.
Thank you.
Starting your timer, and here is your question. Right, so if you have read and understood, considering the communication skills question, kindly begin.
Hello, I am Dr. Saidur Rahman, one of the surgical doctor of this examination. Today, please confirm your name and age, please.
And my name is Mr. X, 30 years old.
Mr. X, I am present the doctor, my consultant of orthopedics, who is busy with some emergency operation, and I come to explain something. Are you okay?
Oh, I'm going for operation, right?
I am so sorry to say that unfortunately my consultant is not present in the hospital. He go for attend an emergency cases. For that reason, we cannot carry out your case today. I'm so sorry for that.
Doctor, already it has been cancelled twice. What you are telling?
Good. Yes.
Okay, I
It was
again
supposed to be
apologize.
my turn.
Yes, yes, I am so sorry, and I am again apologized. But I know, see your note that your operation is cancelled 2 times before, and I understand your trouble. I am so sorry again, but you should know that emergency case should be prioritized first, so that my consult is go away, and I am really sorry for that.
So my case is not an emergency. I have been waiting since so long.
Yes, so sorry. Your case is, I know that you are feeling so pain, but sorry, should say that we should first attend the emergency case that the patient have a life risk. If our consult is not attend, there is a chance of life risk. And so today, for that reason, we cannot continue your surgery.
Can you please call him now and inform him about me?
Okay, sorry. He is busy with emergency surgery at this moment. He is busy, so she cannot able to take his phone.
So if not him, someone else, some other consultant?
Yes, you have right to choose any other consultant, but I am so afraid because if we refer to another consultant, they will take your case study from start. It will also make your time consuming. That will be not good for you.
Okay, well, how about you? Can you do it?
Yes, I'm sorry, I am not authorized here to do such of operation without supervision of our consultant.
How? I have been told that it's an operation. Neither you nor other consultant can do it. Can you please give me one more appointment as soon as possible?
Okay, I am sorry, I cannot give you now available a date, but I will promise that I will take your case in important, and I will inform my consultant about your case and your two-time cancel of the surgery, and as soon as possible we arrange your appointment, and I will inform you.
Okay, you please promise me before that you are not going to postpone me again.
I'm sorry, but if any emergencies arise again, so we should prioritize first the emergency case because there is a life-threatening condition maybe developed.
How can I work now, doctor? My knee is paining.
Okay, if you want, I will give a letter explain that why medical reason your surgery is cancelled and you need more sick leave. If you want, I can call them.
Okay, can I walk on my legs?
Sorry, you cannot avoid wearing any exercise like swimming, or you can go do it, but you cannot do any heavy work, weight bearing work. And I will refer you to a physiotherapist who will give you some exercise that will be extending your knee. And I also give some painkiller to you that reduce your pain.
But I'm having heartburn regarding this.
Okay, I will change the painkiller. That will be help you.
Okay, thank you. Please do the needful.
Okay, thank you. I am again apologized. Please, can I summarize what we discussed today?
Yes, please carry on.
Okay, due to some today you are planned for surgery of knee,
So
but due to
you'll
some
not summarize in this one. In angry patient is very angry and patient will still insist, I want to complain you against you. And then what
Okay.
would be your answer?
Okay, you can sorry, you have a right to complain, but I think it's emergency case, so our doctor should present attend the first emergency case. I hope you will not complain to our consultant against our consultant.
Patient still wants to complain. You tell the patient from where patient can get the forms and what is called.
You can write, you can do anything. So I don't know how to answer here.
Yes.
If
you-
again say,
Yeah, you still have 2 minutes. That's why you have to talk in these 2 minutes
Mm.
with your patient.
okay,
Patient is
please,
angry.
okay, please understand. First, we should priority the emergency case. Emergency like a road traffic accident or some patient that need maybe life-threatening patient can die. Your case is also urgent. I say that to time cancel, but after some painkiller and some physiotherapy, it will be reduced or in next what is we can do. But emergency should be prioritized.
What is patient?
Hello?
PALS.
Sorry. Hello.
Yes, I'll write.
Okay, ma'am, please kindly take over. I'm running out of time.
Okay, yes.
Thank you,
Thank you
brother.
so much.
Thank you. Thank you, brother.
Okay. Any